Welcome everyone here this afternoon to the North Virginia Health Policy Forum. My name is Brady Augustine and I am the Health Policy Director at Applied Policy. The focus of our colleagues at Applied Policy is to help healthcare providers navigate the world of federal and state healthcare policy. We host these monthly events to promote an exchange of ideas and approaches to the multiple issues that define and challenge healthcare providers today. It is no exaggeration to say that hospitals have been on the front lines of the COVID-19 pandemic, managing unprecedented patient needs, addressing catastrophic financial challenges, and securing essential medical supplies. This experience has already changed the way they care for patients in many ways and will have a lasting effect on our healthcare system. And it will no doubt impact policies for years to come as well. Our panel today will discuss what can be improved in the coordination and administration of patient care, best practices in preserving the healthcare workforce, and what hospital professionals can expect in the coming months. Our panelists are Mike Rock, Senior Associate Director of Federal Programs at the American Hospital Association, Len Marquez, the Senior Director of Government Relations at the American Association of Medical Colleges, Association of American Medical Colleges, and Dr. William Rogers, who's the Chief Medical Officer at Applied Policy, but also he is the Director of Emergency Services at a large New Orleans hospital. Each of our panelists will share their insights with you during the first portion of our program today, and then we will welcome your questions. To ask your questions, just put them into the chat box and I'll review them and pose them to our panelists. So with that, I'm ready to go with Dr. Bill Rogers. Bill, are you ready to begin your portion of the presentation?
I am ready as I will ever be, Brady. Thank you.
Thank you.
I'm Bill Rogers. I'm an elderly emergency physician. I've been practicing for almost 40 years. And I'm going to sort of talk a little bit about sort of the clinical issues around COVID, because after all of the other things that we're concerned about really are all based on that. I run a ER in the city of New Orleans. We're a moderate-sized emergency department. We've got 13 beds in the main treatment area and another 8 beds in our fast track area. And then we have a 12-bed observation unit. We normally see between 80 and 100 patients a day in our emergency department. So on January 11th, China reported the first death from COVID. And on January 23rd, China closed down Wuhan because that seemed to be the epicenter. The first person to die in the United States died on January 21st in Washington State, but he had traveled from Wuhan. And then on January 31st, we blocked travel from China. February 14th, France had the first European death. February 23rd, the surge started in Italy. And right about 3 days before that, 1.4 million people came to New Orleans for Mardi Gras. And if you've never been to Mardi Gras, it has to be seen to be believed. People are absolutely on top of each other and yelling at the top of their lungs for hours at a time. If you were an infectious disease expert, you couldn't think of a better way to transmit a highly contagious respiratory virus than to have a Mardi Gras. We had a couple couples come down quite on Charles Avenue with the parades with my friends and with my daughter and her husband and our then 14-month-old daughter. It's a lot of fun, but it's definitely a setup for what happened shortly after that. Mardi Gras ends on Fat Tuesday, which was February 25th. At that point, all of the United States, there have been 14 cases, and they were all travel related. In fact, the first non-travel related happened the day after Fat Tuesday on February 26th in the United States. February 29th was the first US death. A man in Seattle died. And then on March 9th, we had our first confirmed case in my emergency department here in New Orleans. It is remarkable how fast this went. The first 3 days after March 9th, we had about 1 admission for COVID a day. On day 4, we had 3. On day 10, we had 5. And then 21 days afterwards, the first death happened, which is pretty typical of the course of this disease. So how did we respond to this? We brought in staff to the extent that we could to help out, ICU nurses particularly. And we also built a bunch of ICU beds in units that had previously just been med-surg units. And we turned a couple of the wards into negative pressure wards. Normally a hospital doesn't have to deal with that many respiratory transmitted diseases. And so negative pressure rooms are generally would make up maybe 5% of your hospital beds. But with this epidemic, negative pressure rooms were a real rate limiting commodity. We also built what we called a respiratory infection fast track, which was an area outdoors where we could do swabbing and where we could see patients with non-life-threatening symptoms. And that had an advantage of reducing our PPE consumption and also reducing the risk to our employees. We opened the Rift on March 16th, which was 7 days after our first COVID patient. March 26th, the United States became #1 in the world in terms of numbers of cases and deaths. And on April 1st, our census in the hospital of COVID patients peaked at 72 and then rapidly declined after that. So what did we learn from the experience? A couple of things that really stood out. One was that the way we managed the COVID patients changed dramatically. There was so much concern about the risk to the caregivers from the virus that the patients were shedding, that there was a real emphasis, and these were things that we learned from Italy and from the European experience, since they were obviously a little ahead of the curve of where we were. That early intubation would be beneficial. And once the patient obviously was intubated and on a ventilator, then they were exhaling through a ventilator and through a HEPA filter. We learned though, over the next couple of weeks that actually early intubation probably was deleterious. And so we changed our management of the patients quite dramatically with that, with using what we call non-invasive airway support techniques. We also learned, thanks to the British, we were doing a lot of studies with very expensive drugs in the United States, but the British were experimenting with a drug that costs about 10 cents a dose. And it turns out that that drug, Decadron, is probably of more benefit to the seriously ill COVID patient than anything else in our armamentarium. And now that's a routine part of the management of the more seriously ill patients with COVID. We learned that we should minimize admissions to the hospital because we had a limited number of staff to care for people, limited amount of PPE, limited amount of beds, and patients would do just as well at home. So we developed an algorithm where basically if the patient had a good support system and was adequately able to oxygenate themselves on room air, then we would send them home with obviously the promise that they would return if they got sicker. Some hospitals even set up programs where they would send patients home with supplemental oxygen. We never got so overwhelmed that we had to do that. Testing was a huge problem nationwide, really worldwide, because the manufacturers couldn't keep up with the world demand for testing. And the fact that we didn't have available testing early on was a real problem, both in terms of making diagnosis and also not infrequently you'd have to delay an important procedure because you're waiting for 2 or 3 days for the results to come back for the test. Staffing, we learned, was the rate limiting thing that we were worried about. When we first started, we thought that we could send people home who'd been exposed to COVID. We rapidly found out that if we did that, we were gonna have to close the hospital in a couple of days. And recently the CDC's come out with very clear guidelines that if you've been diagnosed for 10 days and you no longer have a fever and you're feeling better, that you're no longer infectious. And so we've been able to use those CDC guidelines to change the way we manage our employees so that we can keep our workforce up. We, as I said, created a lot of hospital beds, created a lot of ICU beds. We quadrupled our ICU capacity. And as I said, we increased the number of negative pressure beds, and we separated out our COVID patients. We still do from our non-COVID patients. Finally, the impact on our employees of this disease can't be minimized. Both the fact that they were actually often shunned in the community. One of my doctors could not get his air conditioner serviced because the air conditioning company that had worked for him for a decade refused to send somebody out to his house to service his air conditioner because he worked in a hospital. And then a number of my doctors and nurses had to sleep in guest rooms, undress in the garage when they came home from work. So it had a huge impact on them and on their families. We had about 5% of our staff became infected. Thank goodness everybody did fine as a result of that, but it was obviously very real to them that this disease was contagious and that we were taking a chance every day when we walked into the patient's room. So I think I finished a little under 10 minutes.
Got to unmute. Thanks, Bill. So, I mean, it always makes it real for us. I mean, as COVID-19 gets closer to each and every one of us and our family members, it's good to know and nice to know, you know, and take care of those people down the front lines and those facilities that are really bearing the brunt of coronavirus. So, thank you for your insight and your experience. And with that, we're going to go, Len, if you can talk a little bit about some early experience from the Epicenters from the AAMC perspective.
Absolutely, Brady. Thank you for that. So, hi, everybody. Len Marquez, as Brady mentioned, I work in AAMC's government relations shop. Just a quick, to let you know who the AAMC is. We represent 155 U.S. MD medical schools, nearly 400 major teaching hospitals and health systems, and then obviously significant numbers of faculty, physicians, residents, employees, et cetera. Really, you know, we often think of our members as, well, they do. They're training the next generation of physicians, you know, all the way from medical school all the way through their residency and training, and then ultimately, hopefully, as they begin to work in academic medical centers. Our areas of focus, though, as you can imagine, with that sort of broad constituency would be certainly the clinical side, so the hospitals and the physicians component, but then also we certainly are very worried and concerned about research issues. So the National Institutes of Health, as well as the CDC, you know, anything related to research. I you know, just point out that you may not realize that half of the NIH's extramural research budget is allocated or you know is applied for and received by you know, academic medicine, by major teaching hospitals. So that's very critical to us and very important to us. And then certainly the education component as well. What we had to focus on from a government relations perspective, you know, in my small shop, my small side of the world, you know, I work on the clinical portfolio. I was worried primarily about hospital, physician, whether it was reimbursement issues, you know, really the provider relief fund, financial relief, and everything that went into that. But then certainly also the need for additional PPE, the need for testing, the need for, you know, relief from regulatory burden. But as you can imagine, we were also very concerned about public health, certainly very concerned about the impact when your when your research labs aren't able to operate? What is the impact of that on the academic medicine community, or on the on the medical school and the hospital, and how they work together? And so that was certainly a serious concern of ours. And then all of the issues as they relate to the students and the residents, and whether or not international residents would be able to get back into the country. Certainly there were questions related to that coming out of some of the administration's moves. Student loan issues. The craziest things, or the things that you wouldn't necessarily have thought of. For example, I don't know how familiar you are with how Medicare supports graduate medical education, but Medicare makes two payments to help support teaching hospitals: direct GME, and that's intended to help support the costs of the actual training. But then there's also the indirect, or IME, the indirect medical education payments. And those are payments that are made to teaching hospitals. They're patient care payments, and they are made to help offset those costs that teaching hospitals incur for services they provide that you may not find in other settings. Trauma centers, burn units, the fact that you are caring for sicker, more complex patients. Medicare has add-on payments that teaching hospitals get because of that mission. That formula, how they determine those payments, is based on the number of beds and the number of residents you have and the number of Medicare patients you're caring for. You wouldn't have thought that because teaching hospitals were increasing their capacity, increasing the number of beds to help with this influx, to ensure that if there was a surge in their community, they could care for patients. They were, in fact, because of that formula, reducing their reimbursement that they would get from Medicare. Now, I will say that was we acknowledged that, realized that quickly, worked with our members on that quickly, and I will say that the administration worked with us very closely to help address that, and basically not make that an issue, to sort of take that off the table, and basically say during this pandemic that increase in beds isn't going to impact your Medicare IME payment. So. That's just sort of one example. I will tell you what we are hearing and what we have heard from our members has just been, and what's been sort of shocking is just as they ramped down or slowed services and began delaying services in preparation for a potential surge, just the loss of revenue, whether it was for our hospitals and health systems. The numbers that we were taking and hearing from our members was anywhere from $2 to $8 million a day for some of them. But then from our faculty practice plans, who, there's an old saying, and I'm sure many of you heard it. If you've seen one academic medical center, you've seen one academic medical center, and the way they're set up. And so sometimes the physicians are employed, sometimes by the hospital. Sometimes they're employed. They're part of a separate entity that's affiliated with the hospital. Sometimes they work underneath the medical school. And so in any case, we had heard anywhere upwards of 50% to 60% reductions in the reimbursement and the budgets for our faculty practice plans, so that was also certainly very very challenging. We spent a great deal of our time in the first months of this. I will just say that so we've spent a lot of our time, at least on the clinical side, focused on how do we support our members, not just protect the financial bottom line. That's not necessarily where I see my role. It's how do we help them preserve their missions, and our members' missions are training physicians, research, and caring for their communities. Patient care. I mean, patient care is a key component of academic medicine, and so we have spent much of our time focused on how do we address that. Now, one of the things I wanted to hit on is the workforce issue. As you may or may not be aware, the AAMC on an annual basis updates and does workforce projections. Our most recent report came out just a few weeks ago. I believe it was mid-June. And we are now projecting that in 2033, it's a 15-year window, that there will be somewhere in the range of between 54 and 139,000 physician shortage. Now you might say that's a pretty wide window, but the reason for that is that there are multiple scenarios and analyses that our workforce center runs to make those assumptions. I think there's two key pieces of that, and that is on our website. And I would encourage you, if you're interested in that, to go to amc.org and look up the workforce section and read that report. It's very interesting. But now it's very alarming. I mean, it was alarming before. It's even more alarming now. The biggest drivers of the workforce shortage are our aging population. There's not much, clearly, I think, that we can do about that, or we want to do about that. People aging, baby boomers becoming Medicare eligible. As people get older, they use more services and more specialty services. The other driver, though, is the fact that you have physicians that are aging and retiring. They mirror society. And whether or not we're able to convince or maintain the number of older physicians who are at retirement age, keep them on a couple of more years, that helps address that a little bit. But I think one of the things to keep in mind is, as we've talked to our faculty practice plans, one thing that's sort of continually come up is we're struggling, but we know that there are other physician groups, practice plans that are going under. They can't, the federal support is not enough, and they are having challenges just staying up and running. What happens if those providers don't come back? What if some of those physicians are retirement age and they decide, you know what, we're done. We're not going to come back. We think that's a real problem. And that 54 to 139,000 range, that was done pre-COVID. I will be very interested. Next year's report, hopefully it's just next year, depends on, I think, how long we're in this. Next year's report is going to look at what were the impacts and what were the effects of coronavirus on the workforce, and what does that mean to ensure that we've got adequate supply. And those are large national numbers, but I really think that, and we all know this, it's our underserved. Sometimes it's the underserved urban communities, it's our rural communities. Those are the folks who are really going to suffer if we're not able to address the physician shortage. And we can certainly talk about what are some of the ways you can do that, but. Very quickly, before I turn things back, I know I've just about at 10 minutes. The only other thing I would mention is that yesterday the AAMC put out a report. It's a blueprint. The name of the blueprint is, and I want to make sure I get it right. As I said, it just came out yesterday. It's a roadmap to reset the nation's approach to the pandemic. And so basically, it's a way forward on COVID-19. And really, a lot of these things, I think, for folks who are in the medical community would make a lot of sense. But just with the numbers, with what we've heard from our members, the impact this is having on their ability to provide care, and in the numbers we've seen of people getting sick and the numbers of people dying, it's just what are the immediate actions the federal government and the country should be taking, and then what are some of the long-term actions. And I'll just tick off a couple of these for you. Won't go into detail, but this report is also on our website. But just some of the simple immediate things are, remedy the critical supply and drug shortage issues, increase availability of testing. I mean, that's clearly, we all know that's key. Establishing national standards on face coverings, and then even establishing and enforcing national criteria for local stay-at-home orders and reopening protocols. I mean, that's just a few of the immediate actions. But then also some of the longer-term actions to dealing with the pandemic. I think one of the things we've seen is the insecurity around healthcare coverage and around access. Those are certainly concerns for us. Absolutely, as we've seen, how COVID is impacting underserved communities, African American community. It's just been devastating. And I think those are things that we really need to look at as a country, and how can we address those. So broadening health insurance and really strengthening the nation's the public health infrastructure. Those are some of the long-term things I think we could be working on. But I think I've gone maybe a little bit over, so I'm going to stop there and hand things back to Brady.
Thanks, Len. So I want to give out two quick shout outs before I hand over to Mike. First is that report, The Way Forward on COVID-19. It is not just a fluff report. It actually has a lot of measurable, actionable items in there. So it's an excellent report. It was my evening read last night. And Dr. Scorton, you may have seen him all over the TV yesterday. Almost every major news outlet was highlighting and citing AAMC. So thank you for that contribution, Len. On the other hand, I want to give a shout out to AHA before I hand over to Mike. So Len was talking earlier about the unintended consequences of expanding our number of beds in order to meet capacity needs, and the unintended consequences on GME payments. AHA took a leading role in pointing out the issues with what is called Factor 2 for DISH payments. And Factor 2 is related to a comparison of a baseline of uninsured to today, and how CMS had recommended in its proposed rule. Their estimate of uninsured for this year is way undercounted. And so it could make a like 30–40% difference in the amount of DISH payments that hospitals across the country will get. And AHA went to great detail in their comment letter to CMS, and then Applied Policy also worked with some of our clients in the same vein and urged CMS to change that, because that could have a huge impact to hospitals as well. So Mike, thank you so much for AHA kind of taking the lead on that. And with that, I'll hand it over to you.
Thanks, Brady. I'm Mike Rock. I'm a lobbyist for the American Hospital Association. We have about 5,000 hospitals, all ownership types, probably in every community in this country. And thanks for having me on. Really appreciate it. And and just in terms of what Len just presented, a lot of those ideas, we fully support, and we'll work together on that stuff. I thought what I'd do is just kind of give you a state of play on where things are legislatively right now, even though, they're not moving so fast. I mean, it's not too hard to give you exactly what's going on now, because it's pretty much the same as it was the day before. And I'm not expecting it to be much different on Monday. However, just to, how is Congress addressing this whole pandemic? As you know, they've passed 5 bills so far, and with remarkable speed. I've never seen Congress do anything so quickly in my whole life. And I think this round may change that. They may be going back to their old ways. So as you know, we had an emergency fund. Now hospitals have gotten about $60 billion from that emergency fund, the $175 billion. There's about $50 billion left there. And, you look at the press and everyone calls it money for hospitals, where, that wasn't just for hospitals. It was for a lot of different healthcare providers. Hospitals have gotten about $60 billion, and you saw how it came out in various tranches, focused on rurals, focused on hotspots, Medicaid providers, et cetera, et cetera. So that's all gone out the door so far. In terms of the Paycheck Protection Program loan program, the SBA loan program, the data came out a week or so ago, 2 weeks ago, and it looks like about almost 1,000 hospitals took advantage of the SBA loan program, which is, can be forgivable. So we'll see how that plays out with those folks. So quite a few, and these were the small and medium-sized hospitals. There was also the accelerated payment program. A lot of hospitals took advantage of that, not all, but there's about 100 billion total. I think maybe hospitals alone are probably about 80 billion of that who took advantage of that. So that, those advanced payments are out there now. However, as you all know, as of August 1, they're going to have to start paying that back. And every Medicare claim they submit is going to probably be paid at zero until those claims are fully paid back. And that's a tremendous concern to our members. I mean, there was maybe some thought back when they did this that this is all going to be over by now, and people would have the resources to pay these funds back. And clearly that is not the case. So that's something we're working on. In terms of what the response has been on this round, do you remember the House passed a bill back in May, $3 trillion package that was, had some good, it had some bad in it, and just a couple of things. They did add another $100 billion for the emergency fund, although we have some concerns about some of the formulas they put in that for distribution. They got kind of specific, so we'll have to work that out. They didn't do much on accelerated payment, even though we were asking for full forgiveness. All they've basically done in the House bill is lower the interest rate from, I think it was an astronomical 10% or something. At some point, we never did get a firm answer about what the payment interest rates would be on repayment, but they lower that to 1%, and then it kind of extend the payment terms. On Medicaid, they gave FMAP a bump of 14%, which we fully support. They also tweaked the Medicaid dish allotments 2.5. On coverage, they recognize the need for continued coverage. They have COBRA subsidies and a whole bunch of other things. In terms of worker assistance, the Healthcare Heroes section of that bill, which we strongly advocated for, there is assistance for dependent care, for bonus pay, behavioral health services, all kinds of good stuff in there we support. On the bad side, they did put in some OSHA requirements, essentially requiring a temporary standard that all businesses and hospitals would have to comply with, and that it couldn't be weaker than the toughest state standards. And at least in our case, that's California. And the problem with this, you put in a temporary standard where we're relying on CDC guidelines and all kinds of other guidelines that are updated quite regularly to conform with some of the new things we're finding out. So we're strongly opposed to this temporary standard they put in on OSHA. So that's where the House bill's been sitting now for 10 weeks, I guess. The Senate, as everybody knows, reads the papers, came out with their kind of response to that on Monday. I guess it's essentially their offer. It was about 6 bills that they're going to try and essentially treat as one bill. But it does a number of things. We have not opined on it officially. So it's still a bit of a moving target, but it does have an additional $25 billion for the emergency fund, which is far short of the $100 billion that we and the nurses and the doctors in a letter a week ago said it ought to be $100 billion, like the House bill. They've given us 25 on accelerated payment, a slight improvement over the House, but still not good enough. They would give hospitals an additional 150 days to start paying that back. So past October, I think it goes to the end of the year roughly when you would have to start payback again. And then they extended the repayment period to 18 months. So a small improvement. There's a lot of stuff in telehealth on that bill, in the Senate bill. A lot of flexibilities that are in place now would be extended through the next year, through 2021, or before the public health emergency, whichever comes first. If you look at that, you'll see that there's a lot of concern in telehealth about fraud. And this is all Chuck Grassley on the Finance Committee. He wants a lot of reporting. He wants a lot of review. So there's a lot of concern about fraud on the telehealth side. So that's kind of what's up there on the Hill, what's been put on the table. In terms of our priorities, I guess we have a list of, I guess it's 5 or 6 pages of priorities, which are ultra priorities. We've narrowed down to about 4. And I would say that full forgiveness of the accelerated payment is number 1. we early on heard from a lot of hospitals who were concerned about meeting their bond covenants. And that was due to the fact that a lot of them had bond covenants that said, we will maintain, cash to debt ratios, for instance, of a certain level. And when all of a sudden you don't have patients coming in the door and you have expenses that are going through the roof, your cash to debt ratio is not going to be probably what you said it was going to be, whenever you issued the bonds or whatever. So this accelerated payment provision is extremely helpful in helping hospitals get through that whole process of how they deal with their lenders and so forth, and for a lot of other reasons as well. It's a top issue. Number two is supporting our frontline workers. We want some strong help for our healthcare heroes in terms of benefits, et cetera. You know the list. Also, another key issue is health benefit coverage. Help people stay on the insurance they have, provide subsidies to employers to help people pay their premiums, COBRA subsidies, opening up the exchanges, et cetera. A lot of things on that front as well. On the kind of second tier, I guess, keep the telehealth stuff in place, get those waivers, make them permanent, increase the FMAP. There's another kind of esoteric issue, at least I thought it was, but it has to do with post-acute providers. You remember Congress, I guess it was back in 2004, said, we ought to look at a unified payment system for post-acute providers, not have all these separate payment systems, for long-term care and SNF, et cetera. And so they started, CMS has been working on trying to come up with some kind of unified system. And this pandemic has pointed up a lot of the problems with how that whole project is playing out, particularly with regard to SNFs. And so what we're asking for is for Congress to just pause any further movement towards completion of that. Also flexibility. In terms of future issues and how we deal with pandemics, if you haven't seen it, I think everybody ought to look at Senator Lamar Alexander's white paper on, how do we deal with future pandemics? He put it out in early June. He asked for comment. We made a number of comments on that, and I'll just quickly run through some of them. We need to modernize the hospital preparedness program, and we've been advocating this for 15 years. It needs more money. We're asking for a minimum of $750 million. In 2020, Congress has given it about $200 million. We want that money to go directly to hospitals and to healthcare providers instead of kind of taking a stop at regional systems and so forth, because the money doesn't seem to get down to the people who are actually providing the care. We'd also like a new fund, just like the emergency fund that's in, the CARES Act, make that permanent and put a lot of money in there that hospitals and other providers can tap into when we get into one of these situations. Also, we need, supply chain. This is something everybody agrees on. Len mentioned supply chains, vaccine research, domestic manufacturing of all the things that hospitals need and other healthcare providers to meet the challenges here. Improve telehealth, continue these waivers and so forth. Because, the telehealth, I think it was essential to flattening the curve here. And we don't want to lose those gains we made, and we showed people it can work. And it's important. By the way, this Ways and Means Committee next week is going to have a roundtable on this whole issue on how to improve telehealth services in underserved areas. That's urban, rural. So look for that. I don't think the date's been scheduled and so forth. So I'm going to stop there. I think I've run out of time and we'll turn it back to you and have a conversation. Thanks.
Thank you, Mike. Thank you so much. So we've got a few questions in the hopper already. If anyone else has some, please feel free to send them to me through the chat functionality. The first one is for Len. So Len, you talked acutely about the workforce issues, and one of the areas that's most unprepared for COVID-19 is rural areas. And the question is, there are statistics, this is from John Voorhees. He says there are statistics that show close to 60% of physicians stay in the area in which they do their residency. and most of these are in urban areas. What do we think the chances are that CMS can revamp GME policy to help build physician numbers in rural areas of the country that are underserved and unprepared for COVID-19?
That's a great question, Brady. Thanks, John, for asking that. This has been one of the challenges we have faced. To your point, generally speaking, physicians stay where they've trained, and it's funny if you look at we do questionnaires at the end of medical school and at the end of residency, and basically the questions. Some of the feedback we hear is that why do people go to rural communities? And very often it's because they're from a rural community. And one of the things we found is, how do you get people to go and stay in rural communities? And all kidding aside, it's have them marry someone from a rural community. Very often, one of the challenges we run into is that you'll have a couple, the husband or wife worries whether or not her attorney husband is going to be able to have a job. Where will he work? What about education? What about the children? There are always questions around that. I think some of the things that we have tried to do to address that, though, there's always the issue of loan repayment programs, National Health Service Corps, public service, forgiving loans for people who go into and stay and work in a underserved community or rural community. I think those work to some extent. I have policy colleagues and government relations colleagues who know more about that issue and the specific workings of that issue than I do. But I think one of the things that we try to do, and our members try to do, the teaching hospitals try to do, is they are trying to get people out of the main teaching hospital, get them out into the community. And whether that's getting them into a community health center, having them rotate through a rural hospital or through a community hospital, exposing them to those situations, giving them those opportunities. I think those are some of the things that we have tried. There's also rural training track programs that folks may be familiar with, and really that's a program that allows, as you may or may not be aware, there is a cap on the amount of Medicare support that a teaching hospital can receive. That's one of the greatest inhibitors to increasing the number of physicians we're training. However, there is a program, the rural training track program, that allows urban hospitals to send their residents to partner with urban hospitals partner with rural hospitals. They can send the residents to those settings to train, and then they can increase the number of residents they're training and continue to claim them and be reimbursed from Medicare. One of the challenges you run into is that you've got a situation where the residents leave, or if you would send them to another setting, then you don't have the opportunity to be reimbursed, and you're still incurring the costs for that training. The last thing I'll mention, one big challenge we have is the cost to train residents. Across the country, it is over $19 billion a year to train the residents. And Medicare is the largest supporter of physician training, and they pay about $4 billion a year. They help offset about $4 billion, and that's in the direct payments. There's also indirect medical education payments that I talked about, and that's another $10 or $11 billion a year. However, that's not an education payment. That is a patient care payment that hospitals, as I mentioned before, are getting because they're caring for sicker, more expensive patients. And the coding doesn't account for that, and they're providing more expensive services that hopefully you don't actually ever have to use. You don't really ever want to be using your trauma centers and your burn units. We know that's not really the case, but I hope that was somewhat helpful, and certainly happy to, if folks want to talk about these things or want information, always welcome. I'm not sure if my contact information, I can make that available, but happy to carry on these conversations.
Thank you so much, Len. All right, so the next question is for Mike and Bill. So we've underfunded public health for about 40 plus years. It's the dog that doesn't bark, so to speak. And so the question is from April Gutman. She says, could we go into more detail about how public health has been underfunded in recent years? How do we improve its use? And how do we help public health plug into the existing healthcare systems to improve its coordination? Mike, Bill, go ahead.
I'll take a crack at that. I mean, I think it's a really good question. The big role of public health in this disease really should be contact tracing and guidance to authorities about infection control measures and things like that, and making sure that the most up-to-date protocols are available to guide the people who make decisions about social distancing and mask wearing and things like that. So they're only part of the problem. And I guess I've been really more focused on the clinical actual management of patients. So it's really good that you asked that question. Unfortunately, there's nothing sexy about public health, and I recognize the service that they get from public health. And so I really don't see that changing. And I think, budgets are going to be so constrained over the next few years because of the falls in tax revenues and the enormous costs inflicted from setting up temporary alternate hospitals and things like that. I don't think we're going to see a boost in public health spending, unfortunately. Mike, what do you think?
I totally agree. I was looking at the kind of history, a bar chart of the history of the last couple of years, well, since 2002, just on the hospital preparedness program. And in 2002, huge spike, of course. Everybody, we even had a little group that we set up called the Partnership for Community Safety that was dedicated to bring together all the aspects of the public health service, firemen, police, et cetera, everybody, the whole community that deals with public safety. And, there was a whole lot of interest in that. Spending went up, and then it slowly declined year after year after year as, the perceived threats went away. And it's just the way, Congress deals with things that are, immediate threats. They have very limited money to play with. And so I just don't see it happening. I can see maybe a spike for a couple of years here, but I don't see any kind of permanent commitment to it.
And let me add, just it may not necessarily take money. Here in the state of Florida, we actually have the Agency for Healthcare Administration that administers Medicaid, and we have a Department of Health that is kind of our public health agency for the state. They don't coordinate at all except in the governor's office. So part of this just may be reorganizing our healthcare system within our state, not necessarily needing new funds, though it would be helpful. All right. Any other questions we've got? Let me see. Let me ask one. I've always been kind of interested in this. So we already spend twice as much as the median country, industrialized country in the world. Where do we think we're going to get the money to address future pandemics or to prepare for public health crises?
Hey, Brady, it's Len. I will just jump in and because I do think this builds on the conversation Dr. Rogers and Mike, had just their answers. And I think the issue is, and this is my sort of personal opinion, I think we're looking at maybe not this year, maybe not next year, maybe not next Congress, but we are looking at a sort of fiscal reckoning is coming. I mean, we are close to $30 trillion in debt, deficit spending. And again, I'm not saying we shouldn't be spending the money we are spending now. I mean, that's why Congress is able to deficit spend, so that they can address these sorts of challenges as they come up. But I do think we are, we're coming up on a time when the last sort of the super committee and their recommendations around cutting spending, That 10-year budget window, I believe, is either up or coming to a close, and those budget caps are going to go away. The question is, what's next? I will fully admit I have not looked that closely yet at I believe it's called the Trust Act, which was part of the Senate package, which is basically deals with for our trust funds that spend over so many billions of dollars. How do we ensure that they are sustainable and that we don't deplete them? And when you're looking at the mid 2020s for Medicare, being out of money, I think Social Security may have a little bit longer than that. The Transportation Trust Fund, I think we're going to look at a time when, whether it's Republicans or Democrats or whomever, there's going to be a lot of fiscal pressure to sort of right the ship, get things sort of back under control. Now, I probably have felt that way for several years, and it hasn't played out. But we'll sort of see how that works going forward. The only other point I would make is it goes back to your question around, spending twice as much. I think that's sort of that gets at the heart of the problem, is that if you look at other industrialized, first world nations, so to speak, they are investing so much money in public health though already, right? They're in the pre-K through 12 or wherever it is, and in public health generally. I think maybe that's where we have shortchanged things. Shortchanged might not be the right word. We haven't made the same investments perhaps as some of our other countries across the world. And so that we end up spending more, for paying for sick care as opposed to paying to keep people healthy.
Yeah, and I just add to that, we don't need more money. There's plenty of money. The money needs to be redirected. I always say, if you get somebody smart enough to go to medical school and you pay them to do things to people, don't be surprised when they do things to people. So when you are in a country where people survive by doing things to people, you're going to find a lot of that going on. And frankly, there's case after case after case where people aren't better off, even though we do things to them. And so, we could buy a lot of spare ventilators by putting fewer marble floors in our hospitals, et cetera, et cetera.
Yeah, and I'll add to that too, because I think when it comes to when they get the menu to look at where do we cut, where do we increase, they're going to look at hospitals, the biggest chunk of the Medicare dollar anyway. And they're not going to reduce benefits to beneficiaries. They're going to reduce payments to providers. And what we've been advocating for years now is to look at some alternative models for payment and get us in charge of community health. Let's improve the health of the community to keep them out of our hospitals. And as you know, I know some of the things we've talked about, Brady, about alternative payment systems and ACOs and so forth. I think those are going to have to come to the fore, and hospitals are going to be in charge of community health. And we got to make sure we construct those new payment systems in a way that makes that a viable option for people. And I think, you can save a lot of money by keeping people out of the healthcare system right up front. And, Congress tends not to, they tend to take a scalpel to things and, or a sledgehammer in some cases, and just cut payments across the board and so forth. So anyway, good question.
Thanks, Mike. So I have one last question. We have a few minutes left. So is preparation for pandemics, social determinants of health, or other population needs, are they considered at all in current payment for performance and value-based purchasing programs? And should they be?
Well, I think they should be, if I can go first. And we've advocated for that. And no, they're not to the extent that they should be. So that's my short answer. CMS put out a little bulletin, I think last week, about giving certain flexibilities. CMMI put it out for these alternatives, but they're not meant to be future pandemic. They were just things to make it easier for those folks to deal with some of the requirements. So, but yeah, I think it should be, and they're not adequately now.
Thanks, Mike. Anyone else want to take that one? We're going to about 2 minutes left, so we may ask one other quick question if you've got time. All right, so I got one more question, and this is for Bill and for Mike, and actually, Len, this is apply to you as well. Outside of telehealth, we've all talked about that. What are the most important flexibilities that we should maintain, at least temporarily, or ingrain and codify into regulation going forward? So all the flexibilities that exist today, the 1135 waivers, which of those waivers exist today that help us, should we keep? Any thoughts?
I don't know, maybe Bill is dealing with them on a daily basis. I don't know.
Yeah, I think the telehealth has been very beneficial, particularly with COVID. And I think probably the alternate care sites and the temporary expansion of capacity by using innovative reallocation of space and resources has been really helpful, and probably should be made an emergency capability for Medicare going forward, so that they can just sort of flip a switch and say, wow, this is another pandemic. I'm going to flip the switch and all of these waivers will go into effect. Because, we really felt, I've got my resident here, and we've been talking about this in preparation, and we really were designing the plane as we flew it. And so it would be a shame if we lost what we've learned from the changes that we made to reimbursement and had to redesign it again when inevitably the next pandemic hits us.
Brady, the one thing I would mention is, we have we've been working closely with our members on this idea of a temporary national licensure for so that to help ease telehealth, but also the idea that some of it has come from our medical schools and from the students who perhaps are seeking care when they're on campus. They go home, or they are in current circumstances under COVID, they go back home to their home community. They've been seeing, whether it's mental health or whatever, they have a provider at the university. They no longer have that connection to that person, allowing that sort of seamless telemedicine type treatment, and ensuring that in times of emergencies, we have the ability to have the physicians able to treat patients.
Thanks, Len. I could really stay here and talk with the three of you all day long, and I'm sure everyone in the audience has tons of additional questions, but I know you actually have other things to do with your lives, but I really want to thank you for being here today. It's been very insightful for all of your perspectives and your insight. I want to thank you all, and for those of you in the audience, who will continue to host the North Virginia Health Policy Forum in this Zoom format for the time being until conditions allow us to meet in person again. And it is international, because we actually have some people from across the country and from other countries as well on the call today. We want to thank you for being here, and we look forward to seeing you next month and continuing our conversation. Now, I'm going to make a pitch real quick. Direct contracting model, I'd love to have a Zoom session on that as well. So we may invite some, if not all of you, back again. Thank you, everyone. Have a good day.